that would be great. Thank you. Okay, so as I said, I'm going to talk to you about the fundamentals of doing puberty research, which is providing where we can a sex and also providing an accurate age for the child. So sexing children is notoriously difficult. Ironically, it's because until the secondary sexual characteristics after puberty appear, the pelvis isn't fully fused, and a lot of the changes that you see in an adult skeleton, maturation that you see in an adult skeleton, don't really kick in. So a lot of the changes that we see, so the masculinization of the skeleton, is about hormones being around for long enough in the body to make extra bone thickening that you see in males and the greater size that you see in males compared to females. So this lack of sexual dimorphism is normally why we tend not to sex children, or it's been considered very difficult. But obviously it's the holy grail of child studies, because there's so many things we want to know about the way that boys and girls may have been treated in the past or differently in the past. Also, they have different survival rates, where boys are more fragile and more susceptible to diseases than girls are. And also, obviously, for us, puberty is really important, because boys and girls go through puberty at different stages. We know that in perinatal remains there is some sexual dimorphism in the womb. So we know generally male fetuses are longer and their bones are denser than female fetuses. But this is also confused by the fact that we know that high levels of stress for the mother in the womb, but also for the child during growth and development, will reduce sexual dimorphism. So in stressed populations, the differences between men and women are seen to be smaller than in non-stressed populations. But what we focus on in both adults and what we focus on in children are features of the skull and features of the pelvis for providing a sex estimate. However, because the child's constantly evolving, because they're constantly growing, there are periods of time where you find that the morphology that you're looking for blurs. So finding the difference between a boy and a girl is very difficult. So the accuracy changes as the child ages, and the rate of sexual dimorphism changes. So these are all things that make it very challenging to provide a sex estimate for a child. For the adults, when we use for all the skeleton, and we're quite well practiced at sexing, we tend to get between 95 to 100% accuracy in our sex estimates, so we can be fairly confident that we're sexing males and females as females. For children, previous studies looked at the sciatic notch, which is this notch, I'll show you later, it's a notch on the unfused pelvis, and tooth dimensions, so measuring particularly the canine, which is sexually dimorphic, and doing males and females that way. But you get about 60% accuracy, which is great until you remember that if you guessed it's a male or a female, that's 50% accuracy, so not great. Some other features, so features that were looked at by Holger Szutkowski, and also Mollison and colleagues in 1998, looked at features of the skull, like the orbit and the chin, and at the mandible. So I've got an image here. So there's a mandible, slope of the ramus here, and the chin. They looked at these features and said that they had 78% accuracy when they were testing that against known sex children. But more recent research done on newly available known age and known sex children from places like Portugal and Spain in particular have provided new tests for accuracy of skeletal morphology, and we're getting about 70 to 85% accuracy now. So things have improved an awful lot in the last, I'd say, 10 years of trying to sex children. So for our purposes, for puberty, it's really interesting to know whether you've got males or females, whether you're looking at males and females and their maturation. So males and females mature at different rates. Females are usually 2 years on average ahead of males. So if you don't know the sex of the individuals, then you're really blurring what you can say about timing of attainment of puberty stages, for instance. They enter puberty at different times, and they have a different tempo, so a different pace of getting through puberty than for males and females. So again, knowing whether you're dealing with a male or a female is really important. And as I said, males are more environmentally fragile, they're more susceptible to stress than females are. And we know that males are more susceptible to delay in puberty, peak height velocity. I mentioned this in the first lecture. And females, because of menarche, we know this is a really sensitive indicator of environmental stress as well as fetal programming. So if we can identify our males and our females in these two samples, then we can look at these kind of crunch factors like PHV and menarche in our different sex groups. So this is why, despite all the challenges, I've pressed on with trying to provide sexing for some of my younger children in the sample. But I hope by the end of this, and by doing a little bit of a quiz at the end, you'll see that to do this, you have to be very robust and you have to be prepared not to sex them and to only have a smaller sample of sexed individuals so that we can be as rigorous as possible when we're applying our methods. So the methods that we use to sex the children for are puberty studies. And so our kids are between 10 to 17 years. After 17, generally, the pelvis is fused. And so those features that we look for on the pelvis that denote they're much broader in women because of childbirth, they're much narrower in men. That morphology is then put in place to the most part after the pelvis fuses. So sexing becomes easier. Still not perfect in young adults, but it's easier. So we focus on different things for children, and we particularly selected for the medieval study areas or features within these areas that have shown the highest accuracy rates based on the populations that they were derived on and other studies that have looked at them as well. So we try to be as careful as possible to select the best features that we can. So I'll go through what these features are with you, but the first one is the distal humerus, where you have the trochlear asymmetry and an olecranon, and we have the medial epicondyle. I'll show you what these features are in a minute. But here you've got the olecranon is the one that has the olecranon FOSSA, that shape has 85% accuracy, which isn't bad going for children. The ilium, this is part of the pelvis, the flat part of the pelvis that hasn't fused yet. You've got the sciatic notch angle and depth and the auricular surface elevation. So for those of you who don't know much about osteology, I'll show you what these features are. And again, the sciatic notch angle here is the one that's seen to be the most accurate at 81% for children, which is intriguing because in adults, it's seen as the least sexually dimorphic feature. So it's quite, it's a very obvious one, and you're seduced by looking at that, but it's not necessarily the most accurate one when it comes to adult sexing. And then we look at the mandible, and the best feature in the mandible is the chin at the front of the mandible. And when we were doing our medieval study and we were publishing the study, in order to define or determine the sex of that individual, we said that 3 features on different parts of the bone needed to agree. So if we had 2 features on the humerus said the same thing, a feature on the ilium said it was a male, and also the mandible said it was a male, then I was happy that it was a male. And we'll look at how you make these decisions towards the end. So I thought I'd just go through some of the features for you. So the image comes from Mary Fallis, who's helping me today. She did some research on testing Roger's distal humerus sexing method. Rogers produced a second paper looking at adolescent skeletons. So in that population, she had individuals aged between 11 and 20 years, which is great for us. And she found that various traits, if you used all of the traits together, the distal humerus at the elbow, you get 79% accuracy. So Kerry in her paper kind of gave you a bit more clarity on the sorts of features that you're looking for, but I'll go through each one. And if you can hear a dog barking, that's my Westie, and I apologise. He's got lots to say for himself. So trochlear asymmetry. So you have the male on this side, where you have, this is the bit where the ulna goes in, so it's at the back of the humerus, the distal humerus, and it's a triangular shape in males and a rounded shape in females. I'm sorry, I'm looking at the wrong bit. That's the olecranon. So the asymmetry, because my slides moved about, so asymmetry is here, looking at the very base. So you can see here how there's an angle, a slope on a male, and it's much flatter or symmetrical on a female. Okay, so that's trochlear asymmetry. Then you have the OLECRANON FOSSA, which is 85% accurate on its own, and the males do have an angular shape, and the females have a more rounded shape when you're looking at them. And then you have the medial epicondyle. So if you held the humerus and looked at it, the distal part end on, you would see the shape here of the epicondyle. It's flatter in males and more angled in females. So females have more sticky out elbows if you looked at them from behind. And this is what you're seeing here, this kind of different angle, carrying angle for the epicondyle. So those are the three features that you would look at on the humerus, the distal humerus, with the OLECRANON FOSSA being the one that you might put a bit more weight on. It seemed to be more accurate. Then when we look at the ilium, so this is what the ilium looks like before it's fused and becomes a complete pelvis. So Holger Szytkowski was the first one in 1995 to point out these features. The sciatic notch, which is here, is something that we look at in adults all the time. But the actual difference that you're seeing in adult males and females is discernible in children, although it changes with growth. So in males, you have a much narrower notch than in females. It's a much broader notch. And this is just denoting the fact that female pelvises are wider in general because of childbirth. They need to have the space when they become fully mature for babies' heads to pass through the pelvis. So you're looking at the angle of the sciatic notch, but also the depth. So if you were to place the bone on the bench and then look at how deep the area is between the bench and the notch itself. So in females, it's much narrower or closer to the bench because it's a much broader shape, whereas males, it's much deeper. Okay, so those are the features, two of the features that are considered the most accurate for looking at the ilium. And then the final one is the auricular surface. This is where the sacrum in the middle of the pelvis attaches to the ilium. In males, it is generally flatter. So it's generally flat, although there's slight raising at the corner, and you may get one of these kind of sulci, these channels underneath. So it's slightly raised at that margin, but in general, if you were to look at it flat on, the auricular surface would be flat compared to the rest of the bone in a male. And in a female, the whole margin of the auricular surface is raised. Okay, so that's the third feature that we'd look at on the pelvis. Then we'll move on to the mandible. So although Mollison and co-worker in '98 looked at the angle of the ramus of so your jawline, they looked at that angle in their study. The chin is the one that's been identified as being the most accurate. So in males, the chin is very round, kind of blunt, and in females, the chin is more pointy. Okay, so this is Szytkowski's diagrams. The flat, blunt for male and pointy for a female. So the newest method is the humerus. That's the one that's probably been added the most recently. But these other methods, looking at the ilium and the mandible, are the ones that have been tested more again and on more larger samples of known age sex children. So I don't know whether you've had time to read the paper that I put up on the website for you, which kind of just summarizes all of this recent research. But the kind of take-home message from these things is that adult sex estimation is still a challenge. It's still not perfect. And age and ancestry can blur the differences between males and females. So Alvarez and Agulia looked at their populations and compared these different traits with their known sex individuals. And they said that the results were better for looking at all of these features if the children were under 3 months. So young infants showed these sexually dimorphic traits much more than older ones. Sutter, however, in 2003 talked about sciatic notch being the best between 3 months and 6 years. So it's not as accurate after 6 years in the population that he compared it against. Whereas Wilson in general in 2015 said the iliac features, so that's the inner surface and the sciatic notch depth and width, saying that these features are more accurate after 10 years of age. And 10 is when children start to enter puberty today. And so this is when the hormones are starting to come in. So whether that has something to do with the increasing levels of accuracy in sexual dimorphism, I don't know. Probably. And then Franklin looked at the mandible. And so while I've shown you the chin, Franklin and colleagues are suggesting that it's actually easier to determine someone's ancestry based on the chin than it is to determine sex. And when they looked at the chin for sexing their known population, they were only right in 59% of cases. And remember, as I said, 50% you might as well guess. So that's not great. So we might put a little less weight on the chin when we're looking at our sexing of our children than normally. However, this might all be moot in future, as one of the most exciting things that's happened in bioarchaeology and child bioarchaeology in recent years is the development of looking at amino acids in the enamel. These are peptides that can give you an XY chromosome result, basically by taking an etching from the dental enamel. And this was developed in Brighton and Durham, where they have tried to resex individuals basically based on this kind of very lightly, hardly destructive at all, very cheap and easy to run sexing method. So I think in the future, puberty studies where we can and it's available will be using peptides to sex individuals and then carry on the puberty method. So everything that I've told you might be in the past. Maybe next year when I talk to you, I won't even mention these other features. But the peptides would also be useful for testing out these morphological features in lots of different populations, because every time they test it on a different group, maybe from Spain or from Portugal or from London, the accuracy rates change because every population has its own levels of sexual dimorphism or levels of stress that might affect sexual dimorphism. So you always have to kind of retest these methods on your own sample or your target sample. So peptides can help us do that. And not everybody's going to have access to the equipment that you need to analyze these amino acids. Okay, so we'll move on to aging and assigning an age to the skeleton so that you can then map the ages at which they attain the different puberty stages. So in most of the studies, and when you're doing puberty studies, it's a pretty good idea to include individuals from the age of 9 onwards so that you can catch any early developers. I mean, if you can, and you have the samples, try 8, so that you're definitely catching anybody who might enter puberty early. So we had some people in our study who had just entered acceleration, started puberty at 9. So we could miss some of those individuals. So to get the full range of variation, 9 to 25 is probably a good age category to work on. So 10 to 25 was the, I said the other day, 10 to 25 is the catchment group that we use for our study, but some people hadn't finished developing at 25, and so that can be extended further as well in some studies. So aging of these adolescents, or the 10 to 25-year-olds, can be pretty tricky for several reasons. The first is that we're using so many different traits on the skeleton to look for puberty. We can't use those same traits to age the individual because it'd be a circular argument. So we have to ignore all of the traits that we're looking at for puberty when it comes to aging, which means you're left with dental development, but you can't use the canine because we use the canine for the puberty method. We know this is very sexually dimorphic, which makes it useful for looking at puberty and hormones. So we look at dental development, but that stops after about 19. So for the older age categories, you're left with the skeleton for aging, and then we're left with the spine, spinal development, and development of the pelvis, or some parts of the pelvis, not including the iliac crest, because the iliac crest is used for puberty. So when it comes to aging, it can be quite a challenge once and when the teeth are no longer useful. So I'll talk to you a bit about how we do the aging methods, what aging methods you can look at. But the best thing to do is the ideal is to be able to do a mean dental age. So based on dental development, you can then plot your individuals in 1 year mean age categories. For the others, where you only have the skeletal age, the second way of looking at it is to put them into age categories. So the age categories that I've always traditionally used and applied in this method were 10 to 13, 14 to 17, 18, then 18 to 22, and 22 to 25. So you can then just look at these different cohorts and look at puberty attainment through those cohorts. But when we looked at delay as a result of pathology, I talked about in the last session, I used the minimum age that someone reached a particular stage. So they were at least 15 or they were at least 17 in order to increase my sample size. So just to explain how that works better, read the paper, and I explain it in the paper how we did that. And that just allowed me to include more people with skeletal development in my assessment. So it increases your sample size, but you're not getting the same resolution as being able to do 1 year age categories, which is the best way. So having originally developed those age categories, I've done a lot more research on adolescents. Recently, lockdown's been very useful for that. And the social anthropologists use and psychosocial researchers use these 3 different age categories, which I think would be useful to apply in the future to looking at early, middle, and late adolescence, because they come with their own particular developmental changes. Some may be the result of modern pressures, that particular characteristics that you're seeing, but others are the result of brain development and hormonal changes that are going to be, constant across the generations and through time. So you have the different physical changes and the different psychosocial changes and characteristics of early, middle, and late. So it might be a useful way of looking at our skeletons by putting them into these 3 age cohorts between 10 and 14, 15 and 17, and 18 and 25. So I'm putting that out there as a kind of a new thing to try. I haven't tried it yet. So, as I said, the best way and the most rigorous way to age the children for the puberty method is through dental age and taking a mean dental age. I used Murray's, Fanning and Hunt from 1963 for the permanent teeth. You take an estimate of the development of the tooth from the mandible. These are schematics of how the tooth develops from the crown all the way to the root until the root is complete. As soon as the root is complete, that's it. You can't age them anymore. You don't necessarily know how old they are, how long the root has been complete, so how old they are from their dentition once the root is complete, or the apex at the very end of the root is complete. So you take an assessment from all of the available mandibular teeth, and then you take an average age of those means for each tooth. If you don't know the sex of the individual, but you still want to use the mean dental age, you should then look at the age table that usually they're everywhere. You can in most publications. Scheuer and Black are probably the clearest publications. So you can then do an average female and an average male, and then take the average dental age using the male and female dental ages. Hopefully that makes sense. So you have one age that incorporates the variation of males and females. It's not ideal, but if you can't sex the individuals, then it's better than not having a dental age at all. We also applied an adjustment that was developed by Liversidge and Mars in 1999 for the 3rd molar. And this just allows you to age further using dental aging further into the age cohort. So they've developed a schematic for the 3rd molar up to 19.7. So after 19, nearly 20 years of age, you're then looking at skeletal development for your aging criteria, because the teeth are now fully formed. So after the teeth, we're looking at fusion of bones that we're not using for puberty, which doesn't leave us with much, I confess, because we've used as much as we could for puberty. So the lower long bones, so we don't use things like the tibia and the fibula and the femur within puberty assessments, so those are okay, you can use those. But within the pelvis, you have the extension of the ischiatic ramus, this epiphysis here, that extends as you get older. So that can get you between 18 and 21 years. S1 and S2, so sacrum 1 and sacrum 20, 25 years. After 25 years, it's when it's fused, that individual is over 25 and I remove them from my study sample, so they're too old for the area that I'm interested in. Fused and fusing ischial epiphyses, so on the ischium. So it will appear and be a separate bone, and then it will start to fuse. So you can use that for aging, and that will give you a nice tight aging. If it's starting, if fuse is great because it always gives you quite a tight aging method. And then the annular rings. So if you're only used to looking at adults and you haven't seen many adolescents, then seeing this kind of very thin flake of bone fusing onto the vertebral body might be quite unusual, but it's fun to find them, and you sometimes find them separately as well, so you can excavate them separately, so look out for those when you're looking at adolescents. But again, the different parts of the spine fuse at different rates and different ages, so use that as an aging method. Medial clavicle fuses towards the end between 21 and 25 years. All of the annular rings will have fused onto the vertebral bodies by 24, so that's getting you up to the age range. So those are the features that we used. These images are coming from Scheuer Black's beautiful images in the juvenile osteology series of books that they have, which I highly recommend. Okay, so I'm sorry the slides are a little bit askew-if today. But in summary, sex estimation based on the distal humerus, the mandible, and the ilium, for now, and maybe in the future for peptides. The distal humerus, the OLECRANON fossa, and the pelvis are considered to be the most reliable. So when you're trying to weigh up how you're going to sex individuals, that would be the best way. Sex is determined best when you're looking at the three different areas. So you've got the humerus, the mandible, and the pelvis, and they're all agreeing. Even if you've only got one feature on each of those and they all agree, then that's pretty good. Then I would assign a sex. Otherwise, you're having to use your judgment and weighing up which you think is the most accurate. And if you're not sure, then don't provide a sex. And just as you would with an adult when you're providing a sex, we give it a male score, a potentially male, possibly male, question mark male score, or an unknown, so just a question mark, don't know, or a female and a question mark, possibly female score. Age estimation, if you can, do it on dental development. I always use Moraes, Fanning and Hunt. There are other schemes out there now that might be more useful for your own particular sample, depending on the ancestry of the group that you're looking at. There's a London-based atlas as well, but they all use the same type of system that Moraes, Fanning and Hunt devised by looking at the schematic of the teeth. Exclude the canine when you're using dental aging because we're using that for puberty. And then once the teeth have developed, you're looking at skeletal maturation, which can help you age up to 20 to 25 years. But we did find that the pelvis is still developing in a lot of individuals after 25 years. So where some of the skeleton is telling you they're over 25, we still had an iliac crest that was still fusing. So there'll be an interesting group to look at, that 25-year-old group. It might tell you that these individuals are delayed. So you use mean dental age where you can, and a minimum skeletal age if you want to increase your sample size to look at things like delay with pathology. And then just off the slide here, I've suggested also quite recently, Sharon DeWitt and I, and it was, I confess, Sharon's idea, to look at the average age of women who were pre-menarche, so where there was no fusion or no appearance of the iliac crest, and women who were post-menarche, so where the iliac crest had appeared and started to fuse. And looking at the average ages between populations, you can start looking at variations in those populations. And we were able to show differences in the mean ages pre and post-menarche in individuals who died before and after the Black Death. So it can be useful. It's a much broader brush way of looking at things. It doesn't give you the age at menarche, but it does give you another way into looking at this data. Okay. So that's all I wanted to say from the lecture. So we can stop recording now, Kerry, if you like.